Well, hello, everyone. Welcome to this pre-meeting ahead of our annual meeting of the Coalition for Operational Research on Neglected Tropical Diseases, or COR-NTD. My name is Chelsea Toledo, and I'm the Associate Director of Communications and Development at the Neglected Tropical Diseases Support Center at the Centers for Global Health, which serves as the COR-NTD Secretariat. I would like to give a brief overview of what NTD is and how today's meeting fits into the bigger picture. Before I do so, I want to give a big thank you to our secretary, Juliet Chami, and to the STH Coalition, along with all the other speakers and moderators you'll hear from today, for their incredible work to organize this event. For those of you who are new to this space, COR-NTD is a group of researchers, program implementers, and their in-country partners with the shared goal of optimizing NTD control and elimination. Its secretariat, as I mentioned, is the Neglected Tropical Diseases Support Center, which is funded at the Task Force for Global Health, primarily by the Bill and Melinda Gates Foundation, by USAID, and through UK aid from the British people. COR-NTD meets annually with the American Society of Tropical Medicine and Hygiene, STMH meeting. The purpose of the COR-NTD meeting is to identify knowledge gaps and next steps in operational research on neglected tropical diseases. This year, like ASH, we've had to make the difficult decision to have our meeting in a virtual space. While meetings with our partners are our favorite time of the year, we're trying to make the new virtual life and to adapt to our meeting accordingly. So one of the silver linings of going virtual is that we are not as constrained as we normally would be by time and space. Therefore, we're able to get better representation of both content and partners to allow conversations to build upon one another leading up to and during the meeting in December. And that's what brings us here today. Today's sessions represents one of 3 sessions on operational research necessary to meet the goals for soil transmithiasis. After today's session, we will host 2 more covering other aspects on this topic. And then at COR-NTD in November, the 3 groups will come together to have a joint meeting and discussion. While this is a bit of an experiment, we expect that the outcome will be a more developed operational research agenda for STA that this already impressive group has already put together. So we're excited to continue with the experiment, and thank you for being a part of it. And with that, I'd like to introduce the moderators of the session, Juliet Chami and Stadel. Dr. Chami is a research group leader in the Nuffield Department of Population Health at the University of Oxford. With a decade of NTD experience, she is particularly interested in improving the reach and effectiveness of preventive chemotherapies for schistosomiasis and hookworm infections. Mr. Nadelajong is a global technical schistosomiasis and soil-transmitted helminthiasis at Sightsavers, with an advisory role in the DFID-funded project accelerating the sustainable control and elimination of neglected tropical diseases, called ASCEND. He will be facilitating the discussion that will take place later on in the meeting. So with that, I will hand it over to Juliet, the session. Thank you.
Thank you, Chelsea, for that introduction. And let me reiterate Chelsea's welcome to welcome everyone to this meeting on integrated strategies for hotspots. But before we get started, we have a few questions that we want to ask you to answer. So a poll will come up on your screen. And if you can just select what applies to you, we're trying to get an idea first of where everyone is tuning in from, what is your sector of employment, and then we have one additional question after this. So if you just take a moment and click what applies to you. Okay, then we'll be able to share those results and move on. Okay, so you see most people are tuned in today from North America, and we have a relatively even split between people working for non-governmental organizations and academic institutions. So my next question then to you as the audience is, what first comes to mind when you think of hotspots? We want to get an understanding of what assumptions or preconceptions you already have before we begin this session. Okay. So we could share those results and then see where we're at with the hotspot question. Okay, that's quite interesting. So most people selected, or the most often selected response was just simply high infection prevalence. Now, I didn't pose that question because there was necessarily a right or wrong answer, but to make the point that through this session today, we want to emphasize that there really is no single agreed definition of hotspots. This term is frequently and rather I say loosely used within the NTD community. So what our goal is today is to simply provide a framework for better identifying and addressing hotspots without providing a single definition that's reliant on one disease ecology. So we want to move beyond focusing on mapping exercises and looking at single disease ecologies, because the context of a number of MDA programs today is that they have mature and well-established monitoring exercises and mapping exercises to know where high infection prevalence occurs in the country. But that's simply not enough to develop more targeted approaches to hotspots or to narrow down the causes of problematic areas. So the aim of today's session is to see if we can find some sort of common ground to develop a framework for identifying and addressing hotspots for both schistosomiasis and soil-transmitted helminths. And just to give a brief overview of the session setup, we're going to have a set of 4 talks, about 12 to 15 minutes in length. And after that, there will be a speaker panel and an audience discussion. So we will all stay in the same Zoom room, and we encourage you to interact with the panel and also to contribute through the chat box. So there will be people that are constantly monitoring the chat box for your questions and for your comments. And then those will be selected and posed to the panel. But if you want to actually ask a question yourself or make a contribution in the second half of the session, then if you could just select the little blue hand that's provided in the Zoom options, and then we can call on you later on and you can turn your video on and make a contribution. So now, without any further waiting, let us move on to the talks. These are 4 pre-recorded talks, so you might see that the speakers will be engaging with you in the chat box, so don't be surprised. Our first speaker is Professor Peter Diggle. He's from Lancaster University, and he's an expert in geostatistics. He's really made seminal advances in how we understand spatial and temporal data. And today he's going to be speaking about co-sampling strategies for schistosomiasis and soil-transmitted helminths. So please, welcome, Peter.
Hello, everyone. It's a pleasure to be able to contribute to this meeting. I'm going to report on some work that's been done by our research group in Lancaster, the names of which you can see in front of you. And in some ways, it's a follow-up to the plenary lecture that I gave at last year's COR-NTD meeting in DC. I want to emphasize that apart from overall funding of our activity by the Bill and Melinda Gates Foundation and the Task Force for Global Health, this particular work is funded by Evidence Action. I know that there will have been some general discussion of hotspots before you hear this presentation, but I just want to give you my personal take very quickly on what a hotspot is. And it seems to me fundamentally a hotspot has to refer to a region of geographical space, but it also, at least implicitly, refers to a time as well. So I'm going to say that something is a hotspot if it's a region within which the current population weighted average prevalence of the disease in question exceeds an agreed threshold, which would be cause for concern. And from my perspective as a statistician, it's essential to realize that you can never be certain that a given region is or is not a hotspot, because you cannot, in practice, ascertain the exact prevalence of the complete population at risk. And so I think it's worthwhile distinguishing a hotspot from an operational hotspot. And an operational hotspot means that there is a criterion that you can determine that will trigger a specific response over the area or set of communities in question. So my working definition of an operational hotspot is that it's a designated spatial region or set of communities where an agreed population weighted average prevalence or other target for prediction is highly likely to exceed an action threshold. And I don't believe there's any way of escaping the fact that the best you can say is highly likely. You can never be certain. To me, that means that hotspot fundamentally is a prediction problem. And a prediction to me simply means the ability to make a probability statement about something that you can't directly observe, but about which you get partial information from things that you can observe. And the triangle on the right is the way I often try to indicate to my students the role of statistical method within scientific method more generally, which is that scientists are trying to understand something about the state of nature, and they advance their understanding either by theoretical understanding of the underlying process, which generates a model, or they advance their understanding by observing how that process has worked itself out, and that generates data. And statistical inference is the process by which you build a bridge between the empirical information in the data and the theoretical information in the model. And by combining those to best effect, you get the best possible prediction of the quantity that you're interested in predicting, the predictive target. So onto the specifics of what this talk is about. We were asked by Evidence Action to help them plan for 2021 impact surveys in Kenya, assuming, as we all hope, that the state of the world will be such that we can actually conduct these surveys next year as planned. And the information that we had to guide us in this task was some historical information from Kenya on prevalence of both STH and schistosomiasis in a range of communities across Kenya. And you can see from these tables, I don't want you to try to absorb the detailed numbers, is that collectively this is a very extensive set of data covering many schools and many persons over 3 survey years, and that there's an enormous variation in the prevalence of either of these 2 diseases across the country. Now, we want to use this information to help us design the 2021 impact assessment surveys. We'd like to design surveys that can co-evaluate STH and schistosomiasis prevalence. And apart from these prevalence data, we've also got information on how NDA has been rolled out at various times historically, and we will have information when we're doing the actual design for the survey of MDA that's been conducted since 2017. And again, this is highly variable. And finally, because the conditions suitable for vector transmission are driven by environmental factors, we will incorporate environmental covariate images of things like distance to the nearest water body, height above sea level, and so on, vegetation, in our predictive model. Our design strategy then proceeds as follows. First, we'll use all the information that was available in 2015 to model the prevalence surfaces in 2012 and 2015. And we'll use that model and data to predict what we would have said in 2015 the prevalence surface would look like in 2017. And because we've actually got the 2017 data, we can validate that model. Having validated the model to our satisfaction, we'll use it to predict the prevalence surface in 2021. And we will use that predicted surface, and in particular the statistical properties of that predicted surface, to optimize the 2021 sampling design within cost constraints specified by Evidence Action. And that's like any design calculation. You have to make an assumption about what you think the world will look like in 2021. And on that basis, you can design an efficient sample survey to answer the question of interest. This is the only slide on which I'm going to put any mathematics, and it's really just to make the point that when you're doing geospatial modeling, you start with classical regression models, and in this case it's a logistic regression model because the fundamental outcome is a prevalence outcome, in other words a proportion, and you incorporate binomial sampling distributions. But the extra ingredient that we advocate very strongly in our research group is to recognize that measured covariates, observed properties, explained variation can only tell part of the story. And we also have to add unobserved, unexplained variation, and we model that as a stochastic process. And we need both in our experience in order to optimize our predictions of what we're interested in, which is the prevalence surface across the whole of the region of interest. And the bottom line is that we insist that we would always use efficient statistical methods to make probability statements about that underlying prevalence surface. Or, and this is important, whatever property of that prevalence surface will determine the public health response. That goes back to the operational hotspot idea, we want to actually predict something which will or will not result in a particular action being taken. And it's not for us to specify as statisticians what that target is. But I'm going to take it for the purposes of this talk that it's going to be based on the population averaged prevalence of disease in a designated region. So how well does the model fit? If we use the 2017 data, we can make our best guess of the prevalence map of STH, and it looks like the left-hand panel here. And if we use only the pre-2017 data, what we would have predicted that map to look like is over here. And I think you'll agree there's a very close correspondence. There are obviously minor discrepancies, but we were happy that this was a well-validated model that was effective in making predictions based on past prevalence data, intermediate mass drug administration information, and current environmental covariates. Now, what are the design considerations here? 3 questions really determine the design. How many schools are we going to sample? How many children per school are we going to sample? Beg your pardon. And which schools in particular are we going to sample? And on the right-hand side here, I've shown you what you might think as a traditional textbook recommendation to sample at random, giving you a very scattered set of sampled schools. And what we prefer is what we call a spatially regulated sample, whereby we still use a probability sampling scheme so that the samples are unbiased, but we spatially regulate them across the area of interest. Then, and importantly, we work within a cost constraint supplied to us by evidence action. So if S is the number of schools and C the number of children per school, these numbers of $200 per school and $10 per child within a school are Mark Minery's numbers, not ours. They're guesses, they're educated guesses, and Mark also has a view of what the total feasible cost of the survey is going to be. So we then get on to the nub of it, which is how do we optimize the design? And the first thing we do is address the first 2 of our 3 questions, namely how many schools and how many children. And we also compare the spatially random and the spatially regulated designs. And in terms of how well we're doing with our design, we need a performance criteria. And we would be receptive to being told that this was not the best performance criterion and we would use a different one, because this is very much supplied by the customer, not determined by us. But we adopted this performance criterion of what proportion of counties in Kenya do we correctly classify by reference to a published set of guidelines as to what you would do, ideally, in response to knowledge about the prevalence in the county in question. At one extreme, if you believe the prevalence to be less than 2%, no preventive chemotherapy is recommended. And at the opposite extreme, if you believe the prevalence to be greater than 50%, you would be recommending preventive chemotherapy 3 times a year. This obviously has to be moderated by local considerations of practicality and resource limitations, but in principle, that's what we like to do. And these diagrams at the bottom show you 2 qualitatively unsurprising facts. As you increase the number of schools, you increase the proportion of correctly classified counties. As you increase the number of children per school, you increase the proportion of correctly classified counties. They also show you, if you compare the red with the green, the red is the spatially regulated and the green is the spatially random of the same size, that the spatially regulated always beats the spatially random by a non-trivial amount. Now, currently, that doesn't take any account of cost considerations. So they come in as follows. Mark gave us 4 indicative budget limits, and within those budget limits, we had a map of all of the schools in Kenya and rough idea of their roles, their numbers of children. And we then therefore looked through that whole space of potential schools and numbers of children per school to come up with what was the optimum performance by the stated criterion of the proportion of correctly classified counties according to the 4 cost constraints. We can't always match them exactly because there are a discrete number of possibilities, but pretty much we match them. And you can see inevitably, this is what you get for your extra money in terms of that performance criteria. Whether that's worth it is not for me to say, but it quantifies the balance between spending extra money and getting extra performance. And I want to emphasize that if a different performance criterion is more appropriate, the methodology that we use is agnostic on the performance criteria. The customer tells us what the performance criterion is, we optimized it. So, in summary, firstly, what I've shown you so far relates to STH, and when we started this work, we anticipated that the scales of variation in STH and schistosomiasis prevalence could be materially different and therefore would need different study designs. Now, in the event, the environmental covariates accounted for the different scales of variation, and in particular, picked up the focality of schisto because of its location close to water bodies, which was an important predictor. Whereas for STH, that was not such an important predictor, and other variables came into the equation. When we'd allowed for those measured covariates, the environmental covariates and the MDA history, the properties of the residual spatial variation are very similar. And the implication for that statistically is that the same survey design is near optimal, won't be optimal, but is near optimal for both. Now, had we not been so fortunate, our backup strategy, subject to its practical feasibility, would be to advocate a two-stage adaptive design, in which you use a single design for both diseases initially, using this spatially regulated prescription and spending a fraction of your budget, possibly quite a large fraction, but then following that up by targeting phase 2 designs at the areas where, according to our methodology, we genuinely do not know with a high degree of certainty whether your intervention thresholds have been exceeded. So, what we found is that variation in prevalence of both STH and schistosomiasis in Kenya show spatial correlation that persists after you've adjusted for disease-specific environmental covariates. That implies that geospatial analysis gives substantially more precise predictions of county-level prevalence than the currently used methods of analysis would do. I haven't time to go into the details of what they are, but you probably know them better than I do. Locating sampled schools in a spatially regulated manner brings benefits over spatially random sampling. And to summarize in a single statement, geospatial methods enable future surveys to be designed and analyzed to deliver more accurate predictions at lower cost. And the general methodology that underlines all of this is in a book that was published last year. And the most recent published account of our applying this methodology in an NTD setting, in fact, to lymphatic filariasis mapping in Ghana, is in this paper published in the Journal of Infectious Diseases. So thank you for your attention.
Thank you, Peter, for that excellent talk. It was quite interesting to see that even with diseases of vastly different ecologies, a spatially regulated sampling frame will still outperform a random sampling strategy for both. So that's something to keep in mind. So our next speaker is Professor Dan Coley. He is Emeritus Professor of the University of Georgia, and he was the director of SCORE, which many of you will be familiar with. It's an evaluation and research program for schistosomiasis. And he's going to talk to us about how you can identify schistosomiasis hotspots based on mass drug administration responsiveness.
Thank you, Juliet, for that introduction. I'm going to talk about persistent hotspots from the perspective of the SCORE studies primarily. And you can see on the first slide here that a number of people have contributed to this, mainly from here at SCORE and in Mwanza and in Kisumu. Next slide, please. So first thing is, what do I mean by persistent hotspots based on MDA responsiveness? It's a location where prevalence and/or intensity does not show a reasonable decrease in prevalence and/or intensity after at least 2 annual or biannual MDAs with good coverage, and we call that 75% coverage of the population that you're targeting. The SCORE definition has been that it's a place that has less than 35% decrease in prevalence and/or less than 50% decrease in intensity. Now, to give you an example of that, if you would advance it, please. So this is a slide, part of a slide from Evan Secor at the CDC, and this shows in the 6 arms of one of the SCORE studies, and these arms are defined in the little red outline box as community-wide MDA every year, or community-wide for 2 years, and then school-based, or community-wide and then holiday or no drug for the last 2 years, or in arms 4, 5, and 6 in this slide, school-based every year, school-based with 2 years of holiday, or school-based holiday, school-based holiday. And what you see in the prevalence curves shown is that there's a fair number of schools or villages that simply did not respond. They are still very high. And if you'd advance it again, please. This is also true of intensity. And so where you see those dots up above the boxes, those are really unacceptable changes over 5 years after 4 years of MDA or every other year. And that's just not acceptable. Advance it, please. And here's the credit for the slide. This came from the Kenya SM2 study in SCORE, and it's village level data at year 5 after 4 or 2 MDAs. But regardless, there are villages that simply didn't do well. Next slide, please. So how often did this happen? Well, it turns out that there were about at least 30% or more persistent hotspots in every arm, every one of those arms with different treatments, regimens, in every SCORE gaining and sustaining study. And here are the 5 studies. The studies at the top are starting at high prevalence, and that's Mozambique, Tanzania, and Kenya. Studies at the bottom are starting at lower, that is 10 to 24% prevalence. And you can see that the percent of persistent hotspots, which is what's shown on the y-axis, is pretty high. It's pretty high in Mozambique and Tanzania, but it's also pretty high even in Kenya and when you start at a lower prevalence. And there's some reasons for that, perhaps. Advance the slide, please. Advance it. So all studies had persistent hotspots in all arms, but the populations and the proportions differ, and maybe for different reasons. Advance, please. So for one thing, in Mozambique, there was very low school attendance. And so while we got pretty good coverage of who was there, but there were a lot of people not there. And in Tanzania, advance it, please. In the last year, which is what we're basing this on after 4 years, there was extremely high transmission in that year. And we don't know why. But I think if you look at Kenya, what you see is quite a few persistent hotspots, even where things work. And that's again with the definition that we were using. Next slide, please. So persistent hotspots were identified in all of SCORE's large MDA studies. And I think we saw these, and it was highlighted in them because we had a large number of villages in each study. There were either 75 or 90 or 150 villages in these studies split up into several different arms, but we can see them in all arms. So based on the SCORE data from these studies, persistent hotspots are not due to low coverage. We checked that, and that's not really the reason. They aren't due to differential high starting prevalences, and they're not due to differential high starting prevalences of heavy infections. All of those canceled out and were not responsible for persistent hotspots. And there we've published these data. So what determines if a given village might become a persistent hotspot under annual MDA? Well, for one thing, Ryan Wingard showed at CDC using the Kenya data that spatial arrangements can be part of this story. So being close to the lake and that sort of bunching up showed that there were some spatial relationships. This was true in Kisumu, but when he did it with the Mwanza data just around the lake in Tanzania, it didn't hold. Now, SCORE has funded several studies in Kisumu and Mwanza to try to compare between persistent hotspots and responder villages. Unfortunately, primarily due to interruptions due to the pandemic, some data collections, analyses, and manuscripts on these studies are not complete. We'll look at some of the preliminary data, but they weren't complete. Next slide, please. So the preliminary data from the SCORE factor studies, as we call them, comparing persistent hotspots versus responders after 5 years of MDA with good coverage, we find that in Mwanza, households that have latrine with a latrine or toilet, you can see that there's 88% of them in persistent hotspots and 98% of them in responders. Now, it turns out in the comparisons, the statistics show that that's significant. It's not a big difference, but it is significant. Now, the percentage of open defecation was greater in persistent hotspots versus responders, which you might expect from the line above. And the percentage of open water usage was higher in persistent hotspots than responders. Now, a published study from Joseph Mwanga in Mwanza did show that this was a social studies kind of a study. He did key responders and various groups of people. And what he found was that in persistent hotspots, there was very, very little community involvement and community really dedication. Whereas in the responder villages, the leadership was right on top of it, and so was the community. So in the responder villages, there was what he called in the social sciences action competence. And that was really quite distinctive. Now, I'm not a social scientist, but based on his study, leadership in the community and then community follow-up is really important in making a village a responder village as opposed to a persistent hotspot. Now, in Kisumu, the studies aren't complete either, but households with a latrine or toilet, there were fewer in persistent hotspots that had latrine or toilet than responders. They haven't been analyzed yet. But again, the percentage of open water usage was higher in persistent hotspots than responders. So again, maybe a reflection of some of that action competence that Joseph saw. There were no differences seen in either country in regard to the amount of migration or movement, or really about knowledge about schistosomiasis. Next slide, please. Now that persistent hotspots are recognized as real, and I think that most people realize these are existing, what needs to be done about them? Well, first, they need to be defined, and we'll come to that. Next, they need to be identified as early as possible, and we'll talk about that. And third, they need to be changed into responders by adaptive interventions. Next slide, please. So how about defining persistent hotspots? Can you use absolute change in prevalence, or percent change in prevalence, or absolute change in intensity, or percentage change in intensity, or combinations of either absolute or percentage change in prevalence and intensity? This may differ for different areas because it may be that the starting prevalence makes you choose one or the other. For example, if you are in a very low prevalence area, then changing from 5% to 3% is one thing, 5% to 4% is another thing, and what do you go by? So I think it depends on what's feasible with the assays and time available and the purpose, whether it's for research or a programmatic definition. And I think that's important. We need to grapple with that. Probably the percent change in prevalence is the most feasible for national programs, or at least I would expect so. And talking to some program managers, that's the one that they seem to be able to do with the most confidence and ease. So that's the one I would go with right now, is just percent change in prevalence. Next slide, please. So how early can you define a village that is a persistent hotspot when you're doing annual MDAs? So these are data from the Kenya SM2 ARM4, where they got school-based every year. And they're split based on the definition at year 5 into what was likely to be a persistent hotspot or a responder way back in the beginning. And what you see is that that split makes a big difference because we're always looking at averages. Next advance, please. So at this time point, that is after 2 years and just before the third MDA, I think would be a good time. And we're trying to convince people that that would be a reasonable time to do a survey just before you do year 3 MDA. Next, please. So if you monitor prevalence just prior to year 3, you can identify persistent hotspots pretty consistently and therefore adjust your year 3 intervention to deal with those. And you might be able to deal with the responders differently, and I'll come back to that. Next slide, please. So why do you need to do this? For one thing, leaving communities as persistent hotspots means that you're not achieving your goal across your entire population. You're leaving many people in persistent hotspot villages with infection and morbidity, and you're allowing them to continue to contribute to high rates of transmission. You want to stop all 3 of those things. So what intervention adaptations can you make? Well, this may be dependent on local factors and underlying transmission, but they include things like shifting to biannual MDA and maybe timed MDAs in places with seasonal transmission, snail control either through mollusciciding or water engineering, or enhanced wash efforts, which would always be a good thing, and encouragement of societal changes. We go back to that leadership issue. Next slide, please. So this is a slide I showed last year at the American Society for Trout Med Hygiene. I've changed a couple of things in it. But I think first we have to define, over in the needs column on the left, define the persistent hotspots for your program. And the targets that we use in SCORE may or may not be the ones that you end up with. But then what I would recommend is that GSA, WHO, other bodies determine based on the evidence what is a programmatically acceptable definition for persistent hotspots. The next thing on the left is to identify them. And as I've said, I think your monitoring surveys before the third annual MDA could show as soon as possible what you ought to do. And I think we could agree with that term, or someone needs to agree with that term, and perhaps it ends up in the guidelines. And then the third is the adaptive strategies. And I think that the target is to turn all persistent hotspots into responders. And depending on the goal, you can move to biannual MDA, which is probably the easiest, although it may or may not involve too many resources. But then the last one down there is to consider biennial reduced MDA, that is every other year for responder communities. In other words, adjusting. So PHS gets more, responders get less. And why do I think that's possible? Next slide, please. What do we know about these adaptive interventions? Well, in our feasibility studies in Kisumu and Mwanza, some of which got interrupted by COVID, but they were based on Charlie King's SCORE RAP #1, which was published in PLOS NTD. In Mwanza, community-wide MDA in schools 6 to 8 weeks apart were very widely accepted. It was totally feasible to go back to the communities and give them praziquantel 6 to 8 weeks later after your first MDA. And that was true in Mwanza. It hasn't been analyzed yet in Kisumu. But one other adaptive intervention aspect that's now been analyzed using the 5 SCORE gating and sustaining studies is how do responder villages do if you move to every other year MDA. And that's on the next slide. So these are new data, and the way they were derived was that Nupur took the responder villages based on our definition from each of the 5 studies, and we plotted those for arm 6, and which from the SM2 studies or the SH2 studies, that is the high prevalence studies, or arm 3 from the school-based studies. That arm is every other year treatment. So if we go back and look at the prevalence and intensity of heavy infections in the responder villages over the years that they got every other year, you can see in every case, the responders continue to respond and even go down with every other year, which I think means in these 5 different studies in 3 different areas means that you can adjust, and responder villages are going to do pretty well, in fact, very well, with biennial MDA every other year, allowing you to emphasize your PHS. Next slide. So in summary, we don't have all the answers, and the evidence is coming from not so many studies, 5 different studies in SCORE and a few other studies. Persistent hotspots will emerge during MDA programs, that much we know. Factors causing persistent hotspots need to be identified and validated because our factor studies aren't complete and we need more. Persistent hotspots need an agreed upon programmatic definition. Researchers can do whatever they wish, but programs need a real definition that's agreed upon. Persistent hotspots need to be identified early. The earlier the better, but after 2 years and before the 3rd year seems to make sense to me. Persistent hotspots need to be addressed through adaptive interventions, and adaptive interventions can allow reallocation of resources between the persistent hotspots and responder villages. Next slide, please. So thank you very much for listening, and thanks, of course, to all the SCORE consortium, and especially those teams that contributed to today's presentation. And next slide, please. And of course, to the Bill and Melinda Gates Foundation for 10 years of generous support to SCORE, which has now ended. And I appreciate everyone being a part of it and contributing to it and reading about it.
Thank you, Dan, for that excellent talk. I thought something interesting that emerged from that talk was addressing the question of how mature do MDA programs need to be before you can recognize that they have hotspots. And it seems from Dan's presentation that they can be recognized really quite early on, perhaps after year 2 of annual MDA. Now, moving on, we're going to hear from Dr. Narcis Kabatureni from Uganda. He is the Uganda lead for the current Ascend project, but he has decades of experience training many program managers across sub-Saharan Africa. He worked previously for SCI, and he set up the schistosomiasis control program in Uganda. So we're going to hear from him what it's like to address morbidity within hotspots and what the programs have done and what has worked or not worked.
I'm talking about Uganda schistosomiasis transmission hotspots after over a decade of yearly mass drug administrations. I'm Narcis Kabatureni. I currently work with Ascend. I want to bring you to the historical background of schistosomiasis in Uganda. In 1902, Castellan described the first case of schistosomiasis from Uganda. You can imagine as far as 1902. It was shown to be a serious public health problem in 1950s, according to Dr. Nelson, 1958, and severe hepatosplenic disease accompanied by portal hypertension, bleeding of esophageal varices, ascites were very common in northwestern Uganda, according to Ngom and Bradley in 1972. Schistosomiasis was the second cause of hospital admissions in 1960s and 1970s in West Nile, extreme northwest of Uganda, and the leading cause of hospital death, especially in adult males, according to Williams, 1987. Control of schistosomiasis in Uganda could not start for quite a long time because we did not have money. However, we started getting pieces of money in the Ministry of Health, and in the mid-1990s, limited mapping was done, supported by many the Ministry of Health, World Health Organization, WFP, and Danish Bilharziosis Laboratory. In 2003 to date, SCI joined, and we initiated a program to control bilharzia. Bilharzia map was later on. We also started mapping, and bilharzia map was drawn by 2003, and it was later polished in 2010. The main strategy since 2003 to date is annual mass drug administration and limited health education. Target population is the school-age children in low-endemic foci, but treatment is offered to everyone 5 years and above in high transmission areas. Mass drug strategy, we treat once a year in high transmission settings, and we treat once every 2 years for tests in the low transmission settings. The disease affects communities living along almost all water bodies in Uganda. And our water body, Uganda, is almost a waterlogged country with so many lakes and swamps and rivers. Both urinary and intestinal types occur in the country, and over 90 districts out of 136 are endemic. Approximately 16.7 million people are at risk of infection, but currently we believe about 7 million people are infected. We have been doing lots of monitoring. We have been looking at coverage yearly. Whenever we do a treatment, we get the reported treatment coverage. The reported treatment coverage is reported by districts which are concerned. But we also validate this treatment coverage by doing survey coverage. And here we compare both. Sometimes they underreport, but most of the time they overreport. And we also look at the intensity, we look at egg load of infection, and we also look at prevalence and morbidity. What has been the observation for many years of mass drug administration and this kind of monitoring? To date, there are areas with extremely high rate of schistosomiasis prevalence, over 50%, and this is a very high rate, and in testing over 5% have infection. And there is also severe morbidity despite over 14 years of yearly mass drug administration in some places. But where transmission occurs on smaller water bodies, morbidity has been eliminated and transmission has been reduced. We always validated reported treatment coverage, as I have already said, and coverage of over 75% has always been taken as an effective treatment coverage. Impact of consistent monitoring, validated treatment coverage, prevalence and intensity of infection and morbidity have shown that hotspots exist and are numerous along Lakes Albert and Victoria Shoreline Islands. The MD impact varies even between adjacent fish landing or adjacent villages on the same island. And this is strange because These islands or fish landing islands or mini villages, they are all getting transmission from the same lake, and the lake is permanent, and one would have thought that the transmission potential, the force of transmission is similar from one village to the other, but there are minor differences. It could be due to the shelter, if one village is sheltered from winds, or if one village has mud banks, and one village has sandy banks, and many other factors. Here, I want to show you the preference when we started, and the preference when we started in 2003, and the preference between 2011 and 2015. And you can see along Lake Victoria and Lake Albert, there is hardly anything that has changed. Here you have a slide which shows you the intensity and preference. In 2011, for example, at Kabwagwa Primary School, the preference was 80.3%, and the intensity was 438 eggs per gram of stool. In 2016, it was the preference was 82, and yet we were treating, and we had been treating, and the intensity of infection had risen 748 eggs per gram of stool. And if you take another school, Warukuba, in 2011, the preference was 72%, but in 2016, it was 90%, and the intensity had increased. So there are even these scenarios where we even see increment. In other words, the transmission potential in these hotspots has never been affected. And as a result, you will see lots of people, a lot of mobility. It is in the children below 10 years, it is in the children, in middle-aged people, and it is in adults. And many of them are accompanied with ascites, but there are other people who just vomit blood. For example, if you see that photograph, it is of people who came to the health center because they learned that my team was in the field, and all of them have vomited blood. Some of them have had 2 episodes and survived. But remember, vomiting blood, many of them can die in the episode. And these are the survivors, but their colleagues, many of them have died. And you see, these ones do not have ascites, and the difference is co-infections. Also help to bring that ascites, which you saw in the previous photograph. Further observations, we have seen some areas failed to decline even when the treatment coverage was effective. Most of these areas actually have failed to decline in prevalence or intensity, even when treatment coverage is effective. And surprisingly, some areas were responsive even when coverage was below the effective coverage, at least maybe 60% and above. So reinfections occur more rapidly in hotspots than in responsive villages. Even though areas with poor mass drug administration impact are known, only very few hotspots have been identified. And there are very many, and they are numerous on these 2 lakes especially. The characteristics of the hotspots in Uganda in these areas is high force of transmission, therefore high infection rate. That's where we see it. And we have the papers published in that line. Have poor latrine coverage, hence sanitation is very poor. We also have papers published in this line. Lack of safe water, have favorable ecological factors for vectors, and we have published this work also. Along the Lake Albert shoreline and along the northeastern shoreline and islands of Lake Victoria, hotspot villages are more than responsive locations. Hotspots are sometimes very wide, covering many villages, but they can be as small as a single fish landing site, but occurring over and over again in short distances. Other observations, it has been suggested by Nope Couture 2017, that is the SCORE group, we can increase resources to hotspots by saving resources from responsive locations. In other words, you limit the MDAs in responsive locations, and maybe you concentrate on hotspots. But there is a problem. How do you identify all of these hotspots? Such resources could be utilized, for example, to provide intensive health education, to build skills of frontline health workers in schistosomiasis management, to improve sanitation, to increase the frequency of MDAs, say, every 6 months or every 4 months, a combination of several of the above factors. The challenges where hotspots are more than, the challenge is hotspots sometimes are more than the responsive villages, and it would be difficult to identify all hotspots. Hence, uniform interventions that avoid costs of searching for hotspots in these hotspots in Uganda can be applied. The interventions should be uniform. We should not bother looking for these areas because the hotspots, there are so many that we can hardly identify them. We could not be able to save adequate resources from responsive sites to manage numerous hotspots. However, where hotspots are few, the saved funds can cater for more intensive interventions. But this is not the case in our Ugandan type. Attempted solution. An attempt was made to find out if poor impact of MDAs could be modified through increased frequency of mass drug administration. And this paper has been published, Shabe et al. 2020. CHOA rates was 65% in villages that received mass drug administration every 4 months, compared to 51% in villages that received the traditional annual MDAs, and the difference was insignificant. So here, we have failed to show that even if you increase the mass drug administration every 4 months, you can change the situation. No, you may not change the situation. Why? Because the under 5s were not treated. Under 5s are the majority of fishing communities. They pollute the environment more. They have high infection rates in these high transmission settings. These communities are unstable with lots of migrations, and hence there was lots of mixing up during the experimental, when we did this experiment. And they mixed from the study villages to the control villages, so the mix-up was too much. Sanitation is appalling in the islands where this occurred. Vector snails, included Biophora conifera and Biophora fifera and Sudanica Lake Victoria, and Biophora Stanley fifera and Sudanica Lake Albert, and all of these are very efficient vectors, and we have published this work in 2013. Hence, transmission potential remained the same in 2 study groups. Reinfection remained extremely high. All of these factors call for more research. Mass treatment alone cannot adequately combat bilharzia in high transmission settings, the type we see in Uganda. The phase strategy, that is applying preventive chemotherapy, health education, access to clean water, sanitation improvement, and environmental snaring control and focal residing together, handled together, can be the answer. I wish to acknowledge World Health Organization who has stayed with us, supporting us all through, the government of Uganda, and partners, especially Bill Gates, Schistosomiasis Control Nations Initiative, USAID, RTI, Envision, Danish Bilharziosis Laboratory, NTDs, and WFP, and pharmaceuticals who have been giving us these drugs, and academic research institutions, especially Cambridge University and London School of Hygiene and KEMRI of Kenya, and Division of Vector-Borne Diseases in Kenya, and our Makerere University. Thank you so much. I'm talking about.
Thank you, Narcissus, for that excellent talk. And just to note, Narcissus did want to also add his thanks to the Ascend program at the end. So that talk was rather interesting in showing us what has been attempted in hotspots, and that severe morbidities can persist in areas that have received repeated MDA, but increasing the frequency of MDA might not always be the solution. So I'd like to move on. Our next speaker is Dr. Rubina Imtiaz, and she's currently the Director of Children Without Worms at the Task Force for Global Health. And she comes with us with decades of experience working with very complex public health programs. So we're going to hear from her how we can apply performance-based checklists to assess hotspots.
Dear colleagues, good morning and good evening. I'm happy to be a part of this very important session today on talking about hotspots, which really recognizes the advanced actions and interventions that countries have mounted against some of the commonest NTDs, STH and schistosomiasis, over the last decade and more. As a result of which we are now identifying localized areas of transmission versus generalized transmission that was happening when deworming interventions and other interventions started years ago. So I thought I'd start off by giving you an overview of some global actions which resulted in national level actions in Bangladesh on the STH control program. So as you all know, in 2001, the World Health Assembly passed really a game-changing resolution on addressing deworming systematically for school-age children using the school platform. So following that, many countries started applying systematically for deworming, and some countries went ahead and did baseline mapping for the prevalence and burden of disease. In line with that, Bangladesh in 2005 to 2007 conducted surveys at schools in a limited area in 3 districts out of 64 in the country to determine the baseline prevalence and intensity of STH, and they found that to be quite high, around 89%. Subsequently, when WHO expanded their guidance to emphasize other risk groups like preschool-age children and women of reproductive age came later. Bangladesh then decided to go change their goal to eliminate morbidity from STH. And in line with that goal, in 2016, they conducted discussions with Children Without Worms, and we were all interested in determining the impact of more than 10 years of twice-a-year deworming on the community, the whole community. So with that in mind, we developed a methodology to do population-based surveys at the community level to determine the prevalence and intensity for all parasites for all ages. In line with that, so from 2017 through 2019, we conducted these surveys powered to the district level in 12 districts, of which we are using the 10 district data for this presentation. These are the 10 districts, and you see the colors indicate the prevalence thresholds. There are a couple of yellow districts with prevalence more than 10%, and the orange districts are very high prevalence, Sunamganj in the north and Bhola in the south. Those 2 districts showed prevalence between 30 and 50%, so very high persistent prevalence in spite of reported high coverage. So the 2 districts in the center and north of Bangladesh, we had data that enabled us to go down to lower levels, to the sub-district level. And what this slide shows is in both the districts, you can discern the areas of very high ongoing infection transmission. Those are the red upazilas or sub-districts, where the prevalence was more than 40%. The more granular the data, the better you're able to identify the hotspots. So our surveys define the geographical clustering in space. The seasonality is relevant, but not terribly important for most of our STH. Subpopulations are important to look at. As an example, in Bangladesh, the Rohingya refugees started coming in the southern parts of the country, and that immediately increased the burden of STH in those areas. Hotspot is driven by the prevalence, high prevalence or high intensity of infections. That is important to know because it has different program actions. What can cause these hotspots to continue? That's important in how you approach the assessment of these areas. The commonest causes can be grouped under program areas or performance issues. Just regular monitoring should be able to elicit it, but sometimes in remote areas and for many other reasons, the program cannot keep up with every location. So coverage issues, anything that affects community treatment, coverage levels, whether it's systematically missing the same population or intermittently is important. Are the drugs not getting to the population? Supply chain issues, those are important. Ecological factors are important, and climate change may have a role to play as we go forward in that. Another big reason or cause for a false hotspot, if you will, is ascertainment errors. When you are using somebody else's data, someone else's survey, and you're not sure about the sampling frame or the methods that were used, or the laboratory quality of the tests that were done, then that needs to be thoroughly examined to make sure a hotspot reported is indeed a hotspot. There are drug efficacy issues. Remember, I pointed to the district in the south and the Bhola district in the delta of Bangladesh that had very high prevalence, more than 40%. And when we looked at the species-specific prevalence and intensity from our survey, it showed us that it's trichurus that's essentially driving that high. So that's one parasite out of the three, the ones that we are following in the STH program, that is least affected by a single drug treatment, which most programs use. And Bangladesh has been using mebendazole alone over a number of years. So mebendazole doesn't has the same high efficacy as it does against trichurus as it does against ascaris and hookworm. So that drug efficacy issues are important. Then the quality of drug is also very important. If it's locally procured, need to look at the quality effectiveness. There's a lot of drug pressure in populations treated by single drug over a number of years with high coverage. We know that that has caused resistance across the board in animals, and for every other disease, we use a single drug over a number of years. So it's not a question of if, it's a question of when drug resistance will show up against benzimidazoles. So one must look at that. But first, we need to exclude other more easily accessible causes. So with these reasons and possible causes for continued infection transmission in mind, we developed 3 checklists to assess these hotspots. The first one looks at the quality of the control program. So performance issues, as I just shared earlier. The second one looks at the quality of the survey or assessment errors. And the third one helps to interpret the observed results in terms of program actions. So this is just a quick look at the checklist. These are available on the Children Without Worms website and can be available directly, and we're happy to engage with anyone who wants to use them. What did we do in Bangladesh? We used a team that consisted of the local program staff from the LF and STH elimination program and the Children Without Worms technical advisor. They went out to the 2 sites, which were the 2 districts I showed you earlier, the Sirajganj and Sunamganj, that both reported high prevalence. We selected the upazilas, or the sub-districts that were red, if you remember, very high, more than 40% continued infection transmission in prevalence. The checklist had 46 questions and involved a lot of desk review of documents and records, looking at previously reported MDA data, the trainings, the presence or absence of health workers, the availability of drugs, the timing and occurrence of IC campaigns at schools through the health department and all of those things. We also, in that process, felt the need for and added a behavioral component, which we thought was really important. And that consisted of focus group discussions and intensive interviews with a select group of health workers, school teachers, and community members to elicit the various challenges. The teams went multiple times to these two districts from Dhaka, each time consisting of 2-week periods to conduct the interviews, and they used standard forms to abstract information and analyze that. The results were many very useful outcomes, and we are going to publish them, so I won't get into detail, don't have a lot of time here. But as you can see quickly, there were service-related issues, there were health worker shortages, there were drug supply issues, training issues were there. A lot of times health workers didn't know there was going to be an MDA ahead of time, so they could not inform the community. The community didn't know. Community had a lot of misconceptions and misbeliefs that were not addressed. Community outreach was deficient. Then there were ecological and area-specific challenges. There was low school attendance, very low literacy rate, poverty, hard-to-reach areas, frequent flooding. They had hanging latrines, houses built on stilts. Most of the residents are fishermen. And in seasonal flooding, a lot of those latrines are unsafe, and there was fecal overflow over surface water. So there was no evidence of drug resistance. So the last slide, I will try and encapsulate the operational research opportunities and gaps from our work. We would like to further develop and validate the methods as well as the tools across other countries and ecologies and populations. And more importantly, really, we feel like we can use this method and approach against other PCT-prone NTDs like schistosomiasis and even LF. The use case scenario for these methods and tools is for tier 3 or advanced programs that have achieved high coverage for a number of years. They have conducted post-coverage, post-intervention impact surveys, and those surveys have identified clearly these hotspot locations. We also, as part of the operational research, need to develop training modules and a user guide for national programs. Thank you very much.
Thank you, Rubina, for that excellent talk and for taking us beyond focusing on single issues related to hotspots and a more comprehensive framework. So now that all the speakers have finished their talks, before we proceed to audience questions, I encourage everyone, well, first to write your question in the chat box if you can, to raise the blue hand on the Zoom option if you want to ask it by video. But quickly, I would like to actually invite the speakers, each panel member, to contribute a point that they think is important for the audience to consider when we're trying to identify common ground for developing a framework to assess hotspots for schistosomiasis and STH, or they could identify key differences that need to be addressed. So perhaps we could start with Peter, if you could give us your thoughts on the talks.
Yeah, thank you very much, Jolette. I thought there were sort of many interesting commonalities. Just very briefly, that Dan very nicely emphasized that it's for the people who are running the programs to decide what is the measure of success that would determine what kind of intervention should be made. And his emphasis on a difference is a perfectly reasonable one. And if that's what people want to optimize against, then that's what they should do. I think it's also worth emphasizing, though, that once you've decided what your criterion is, whether it be current prevalence or difference from last time or whatever, it really is important to estimate that quantity as precisely as possible. And it seems a pity not to use the most efficient statistical methods for analyzing the data. I don't want to take time from the discussion, but I could see so many interesting perspectives I could enlarge on. Questions, for example, about what's the relevant unit to intervene on, whether it's the village or the district. Questions about the fact that the factors that affect persistence or resurgence of prevalence are many and varied, and therefore are hard to codify in covariates you can measure. And also the fact that differential interventions in different localities may well make a lot of sense, and that would need to be taken account of in any subsequent monitoring of the effectiveness or otherwise of interventions at a sort of national level, if you like. I could go on, but I know you don't want me to, so I'll leave it there.
Yeah, I think that is actually a lot of food for thought, and it is interesting to highlight the challenges related to formalizing an evaluation strategy for hotspots. I mean, there are so many things to consider. So I actually think from that, it would be nice to pass to Dan, to have Dan. Dan, are you there?
Yes.
I can see your video, but have you contribute a few points before I go to the next two speakers?
Sure. I think that in my estimation, the thing that we need to know next in terms of operational research is a bit more on the factors contributing to persistent hotspots. The SCORE studies on that point were cut short. We don't know the final answers. The one that we do was one that I hadn't expected, and that's Joseph Mwanga's in regard to leadership in the communities, correlating with whether something is a hotspot or a responder village. I think that clearly, as Narcissus appropriately pointed out, the transmission capability in a schistosomiasis community is a driver for sure. But there may be others that contribute to that. And I think more operational research on that would be very valuable.
Thank you, Dan. And Narcissus, could I ask you perhaps to share your thoughts?
Thank you. I think, first of all, I must appreciate that the work of SCOR was very wonderful and raised a lot of points which are very important, and most of which we see them happening in Uganda, even away from the large water bodies. Hotspots can be easily identified within the shortest time, maybe 3-4 rounds, as he says, as the SCOR studies show, and we have seen that too. And the only problem we are seeing, there are too many in some of the high transmission settings that we cannot do much by isolating all of them. That's where I'm saying that you may not be able to manage these hotspots using resources which you save from the susceptible areas, just because there are too many. But in areas where transmission settings are a bit low, you can utilize the funds saved somewhere else and go to the hotspots and concentrate on them. And MDA alone in our setting will not be a solution, and indeed it is not a solution in many areas. And one point I can see, whether we like it or not, it is very good that the SCOR project raised up these hotspots. At least they highlighted the importance of hotspots. We need to do more research on them, understand them more fully, and design how we can really impact them through different interventions. Thank you.
Thank you, Narcissus. And lastly, Rubina, if you could step in, especially since you had more of a bird's eye view to all of the problems related to hotspots.
Thank you, Jolette, and thanks to the other speakers in the session. I think it was very interesting for me to see, I was the only one speaking of STH hotspots. So I would like to hear from your experience in schistosomiasis, where it sounds like, looking at Narcissus' slides, over a 10-year period of successful interventions, you still were not able to make a huge difference, huge impact in prevalence and intensity. And it sounds like the vector, the snails, play a major role in infection and reinfection, whereas for STH, it's a more linear relationship between successive treatments over a period of time. So if you can consistently achieve high coverage from year to year on the same population, you do expect to see disappearance of high prevalence and intensity areas, and you do expect to see localized transmission of infection is really related more to service factors and not to other, there's certainly no vector for STH. So given that, when we are talking about convergence of diseases, especially at the country level, how do you see that coming about when vector control kind of takes you away on a slightly different direction from STH for hotspots? Thank you.
That's definitely an interesting point to consider, and we'll let the other panelists respond perhaps later, but now we want to spend the rest of the time taking the audience's questions. So if you would like to ask a question in person, raise your Zoom hand, and I'd like to pass it over now to Cosmas, who will moderate this part of the session. Thank you.
Thank you, Goyet. Thank you, Peter, Dan, Narcis, and Rubina. We have a couple of questions in the chat. The first question goes to Peter, and it's from Subramanian Swaminathan. He says, partially regulated and spatially random sampling. Kindly elaborate. So Subramanian, if you're there, probably if you can unmute to be more clear on your question, that would be very helpful.
Yes.
I'm happy to analyze it as put, but if Subramanian wants to say something first, he should.
Hello.
I think well, the simplest way I think I could convey the idea of spatially regulated sampling is that as soon as you see a map like the very nice ones that Narcis showed in Uganda, you can see that high and low areas tend to occur in patches. And to the extent that that is true, it means that when you take a measurement at a location, it's also giving you information about nearby locations. And so you don't need to waste your time surveying another nearby location. You'd be much better expending your limited resources in moving a further distance away, where you might expect to see a reasonable change from the place you started from. And the extent to which that's true does vary and can vary very markedly, of course, between different application contexts. And so one should not presume the scale of that spatial patchiness. One should estimate it from the data and adjust your method of analysis accordingly so that you do get the most precise predictions. But I've never yet seen a situation, and there are good mathematical, theoretical reasons for this, where randomly sampling is actually better than spatially regulated sampling. And I've seen many instances of the reverse, where spreading the observations uniformly around your study region buys you extra precision. But it's still critically important that you do that by a proper probability sampling method. Otherwise, you may well induce subjective bias into your results. And then, I mean, then all hell breaks loose. So it's very much based on the idea that information at a point conveys you not perfect, but reasonably good information about what's happening near that point. And therefore, you get more information overall for a given number of sampling locations if you regulate their positions around the space. And I believe in some of the programs, people do that informally already, that they actually aim to have a reasonably regular coverage of the study region. And if they're doing that for intuitive reasons, they're spot on. And it's also a provable mathematical theorem that it's the right thing to do if you're interested in understanding geographical variation in and out.
Thank you.
Thank you very much, Peter. We have another question from the same person. He says, a major concern for the program managers is how to identify hotspots when the program is ongoing, as the environmental predictors are not expected to predict the actual change in indicators. So I'm directing this question to Dan. Hi, Dan, can you hear me?
I have to unmute. I think that's a very valid question because so many programs are already ongoing. Maybe 10 years ago, this question wouldn't have been so pertinent, but it is now. I think that from my perspective, and I'm not a program manager, but from my perspective, the survey that you do, whether it's after 4 or 5 years or at the beginning, whenever it is critical. And I think this goes back to Peter's point. At some point, you need to evaluate what you've done. So if you have an ongoing program and you have an evaluation impact survey, doing it properly will then tell you at that point who is still a hotspot and what has happened in places that have been responding and are going down. So I think that it all goes back to surveys, and it all goes back to impact surveys in the middle of a program at some point. I think that currently for schistosomiasis, the WHO guidelines talk about after 5 to 6 years, an impact survey. I would predict that if you're trying to find persistent hotspots, you can look earlier. And at that point, you're not looking at percent change or anything. You're just looking at prevalence or prevalence and intensity, but I would say prevalence is sufficient.
May I have a question here? I'm Subramanian. Hello.
Could I add a comment, Cosmos? Just a very brief comment to Dan's answer, with which I agree completely. And the corollary to what he said is, I believe that when you are designing that impact survey, you can and should take account of the data that you've seen, not just in a qualitative sense, but in a quantitative sense. And this is where adaptive design, focusing limited resources on areas that are probable resilient problem areas, rather than continuing to sample equally across the whole region of interest, makes a lot of sense.
Hello. I have the question here. May I have a question here, please?
Okay, just kindly introduce yourself.
For example, from our LF experience, because we have the impact evaluation after five rounds of MDA with the DA, after 5 rounds of effective MDA. So what we use is the transmission assessment survey, and the sample size used are for the whole evaluation area. That means the decision can be made based on the sample size. So it cannot be interpreted for the lower levels of that one. So the sample size, the power of the sample may not be adequate to say about the hotspots for a particular school or particular village, community involved in the task. So the identification of hotspots, then it's a problem with the sample size itself. That's my question.
Thank you very much. The next question goes to Peter. Prevalence and intensity are related. Then why use 2 parameters? And this is from Krish Namor.
Okay, well, the answer to that is that, yes, they are related, but not perfectly. And what that means is that information on one, data on one, actually conveys information about both. Now, certainly, if the only practical consideration is prevalence, then it makes sense to focus your effort on collecting prevalence data, and similarly for intensity. But in practice, one has a certain degree of concern about both, and sometimes for either planned reasons or because of the difficulties of collecting complete data in difficult field conditions, you may end up with a data set where one or other of those 2 quantities is missing at certain locations. And so their joint analysis gives you extra information on both. But certainly there's a presumption in collecting both that they are both of some interest, even if one is the primary interest and the other is of secondary interest. And if one is of no interest whatsoever, then of course there is very limited value in analyzing the data on it.
Thank you, Peter. Please feel free to raise your hand, unmute, and I'll be able to let you. This question goes to Narcis, and it's from Poppy Lamberton. Your comments on migration between communities reflects our recent parasite genetic findings too. Do you know if fishermen migration has been reduced by COVID-19 restrictions, and if this might have a positive influence on primary healthcare services where MDA managed to continue?
Thank you, Poppy, for that question. Unfortunately, COVID-19 here in Uganda has not affected the behavior of people so much. On the streets of the Kampala, you will see people, and very few, if you are lucky, they have masks on. And the situation has been worse in the islands. Businesses as usual in the islands. So migrations and everything, the fishing, the behavior is similar as Poppy you already know. Thank you.
Thank you very much, Narcis. This is more of a comment from Clive Schiff. I studied hotspots in Egypt, irrigation systems, and found hotspots based on snail population and infected snails. My point is that we need to study snail populations to find precisely where transmission occurs. I'll direct this question, the next one again, still to Narcis, and it's from David Rollingston. The situation around the lakes remains serious despite numerous studies and interventions. In your opinion, what will be the game changer? This is to Narcis.
I just feel that integrated control of disease is vital. We really need to wash interventions. We need SBCC. We need the snail control, definitely, especially focal snail control is vital. So we need really to integrate these, and especially to identify hotspots, because there are areas which can respond with the MDA, but these hotspots seems a lot more is needed there once identified. Thank you.
Thank you very much, Narcis. Again, feel free to raise your hand, unmute, and you'll be given the opportunity to speak. The next question is from Margaret Baker, and it goes to Rubina. How do we get from longer lists issues found to identify smaller lists of issues that are driving the outcome? So if Margaret Baker is around, please just unmute and probably make a question to be more clear. How do we get from longer list issues found to identify smaller list of issues that are driving outcome? And it goes to Dr. Rubina.
Thank you, Cosmos, and thanks, Maggie, for the question. So as I think I tried to put it down in the chat, that the big grab all category where we saw most of the issues and challenges coming up were program services. So there were many, actions or misses related to missed MDAs, missed communications, both to the peripheral health departments and to the community, misconceptions by the community that were not addressed. And just in short, the areas where we saw these persistent hotspots were very remote. So I think as the program progresses, if I were to summarize it, it's a matter of extending the program monitoring to the areas that are likely to be missing quality services and interventions. They also didn't have WASH. They had low school attendance rate. So the usual things, no magic bullet out there. Thank you.
Thanks very much, Rubina. And the last question on my list is from Sanjaya. She's asking the difference in methodology between sampling for schools and community. And this goes to Peter.
I'm sorry, Cosmos. I was just finishing a typed reply to a question you haven't called. Could you repeat the question?
Yes. The participant is asking about the difference in sampling methodology between schools and community. How does that play in identifying a hotspot?
Yeah, I mean, it has to be context specific, because as with so many things that I have to confess to as a statistician, is that all I can do is add value to other people's bright ideas in this space. So if if the relevant concern is with the whole age range, then that suggests a community sampling frame. Whatever sampling frame is used, then the methodology that I've tried to illustrate in my talk can be applied. And the important thing is to understand how and why the sampling scheme was set up in the way it was, which has to relate to the target population and the target for prediction. But there's nothing inherent to the methodology that is restricted to school-based or community-based sampling. Whatever sampling instrument is judged by the scientists to address the key question at a location can be the starting point for the geospatial design and analysis of the overall survey.
Thank you, Peter. Looks like you have so many questions to answer. There is another one from Diana Tuchel. What will be the difference between a spatially regulated sample and a random sampling design, where the random sampling design is not uniform, but rather is based on probability proportional to size, and the size measure relates to the probability of being a hotspot, in bracket, gleaned from prior survey?
Yes, that was almost the same as the question I was typing an answer to, but a rather lengthy answer, but I'll try to give a shorter one, which is that the distinction between spatially random and spatially regulated sampling can and should be combined with other well-established principles of good sample design. So in particular, ideas like stratifying by prior risk category, or adjusting for things like population density, and deliberately oversampling in areas of high population density that are thought to be more important, all hold and should never be forgotten. So the analysis then has to include, as part of its protocol, those factors that were present in the design. In other words, the analysis has to respect the design, but spatially random doesn't necessarily mean spatially completely random, and spatially regulated could mean spatially regulated having allowed for or adjusted for strata or variables such as population density that are thought to be important in terms of studying the outcome of interest. And certainly, if you want to do a spatially regulated sample that also simultaneously samples in proportion to population density, then the maths gets a little bit tricky, but it's not, I mean, it's not difficult to implement. You know, programs, including ones we've written, can do it. And the important thing is to really do what you would in any design of a sample survey, which is list all the important sources of variation that you want to control for, right? And all the ones you want to adjust for, and making sure that your sample survey respects those, but in addition, spatially regulates the sample locally so as to be able to exploit the precision benefits you get from spatial correlation in the thing that you're trying to estimate. And if what you're studying doesn't show any spatial correlation, there's no advantage or disadvantage in spatially regulated sampling. But again, I go back to the Uganda maps that Narcis showed. The patchiness was very strong, and it would very clearly be a situation there where you can exploit that to get better efficient local estimates, more efficient local estimates through spatial regulation. But you may still want to stratify by the high and low risk areas, and by distance from water body, and by whatever Narcis and his colleagues know from their expertise on the disease matters in terms of determinants of the outcome.
Thank you very much, Peter. That's very much what I had on my list. And I'll pass on to Chami. Thanks.
All right, thank you, Cosmos. I actually want to return back to the panel because there were a lot of points that were brought up that weren't addressed. And Rubina, you have brought up the issue of reinfection rates. Do you think that this is something that will completely stop there being a unified framework for schistosomiasis and soil transmitted heel myths? Because with Dan's talk, he was talking about the responsiveness in terms of prevalence and intensity after MDA. But if there are clear differences with STH, perhaps that sort of strategy can't be used. Could you and Dan perhaps share your thoughts first with Rubina?
I think I want to clarify what I said. I don't think I meant for it to be just dropped, the idea of convergence. I think there's lots of room to, for joint monitoring of these programs. Like I said, as the programs advance, that's when you expect to see more hotspots as you start making impact in some areas. But there is this additional a twist, if you will, or different nature of schistosomiasis where there is a vector involved, which we do not have in STH. Of course, there are reinfections with STH parasites also. And that's why WASH is so important, behavioral change is so important. So those are again areas of common implementation. But given the vectors, it may be good to hear from the countries how they would address it operationally, because in the end, the research is going to be applied at the country level for programs to wipe out these diseases. So how would that work in real life on the ground? And do we need to consider vector distribution in surveys of impact, as an example? I'll stop there and look at Dan.
Okay, I would say that reinfection rates are extremely critical. And here is where actually STH and Schisto are comparable in that soon after treatment, you can get reinfected. This separates them, say, from lymphatic filariasis, where treatment puts off reinfection for a long time. And so I think that the difference there is quite stark. But between soil-transmitted helminths and schistosomiasis, I think it's relatively similar in the sense that the environment, whether it has a vector or not, can reinfect you quickly. I think that in schistosomiasis, certainly as Clive has noted in the chats, there are places where snail populations have correlated with hotspots. We didn't find that in Lake Victoria in Kisumu when Sam Locher looked for that difference between the hotspots and the responders. But certainly if you don't have snails, or if you have a lot of snails, it makes a difference. So I think that snail surveys are useful. If you have hotspots that are simply not responding, that's one of the things you can do, is to find out whether or not that correlates with your hotspots. But as Narcissus said, there are going to be places where you're going to have to use everything you can. And in schistosomiasis, that means dealing with the vectors.
I'll quickly add, if there is time, Juliette. So linking back to Peter's presentation, Peter, I really liked the way you described the hotspots in operational terms. So we do look at hotspots as an operational issue, if you will, because in the end, that's the final challenge, if you will, for the national programs to identify hotspots and then treat them appropriately. And that's why we are discussing all the drivers of these hotspots. So maybe there is a way of oversampling along water bodies for schistosomiasis and along other factors for STH to elicit reinfections, especially as we go on in STH to add strongyloides to the STH agenda, because then you're talking about a whole different level of reinfections. So I'd love to hear from more people on that.
Peter, Narcissus, do you?
Well, just that, just to say that it seems to me, and I hesitate to say this because very much as an outsider, but it seems to me that there must be cost-effective gains to be had from jointly sampling for 2 or more diseases because of what I understand to be the relatively high cost of field work as opposed to the actual drugs that are administered during MDA. And the extent to which you can co-design does depend on the extent to which the variations in highs and lows, or if you like, in places that are hot and places that are not so hot, to the extent to which the 2 diseases co-vary. And clearly in some cases they do. And so I think the potential for economies of scale and cost-effective improvements, and therefore better precision and better decision making for fixed cost, I see the potential for those must be there. But at some point there is going to be a compromise, because when you're optimizing something, you have to have an optimization criteria. And as soon as you're dealing with 2 or more diseases, you then have to have a debate on what you're going to prioritize. You know, an efficient, precise answer to an STH question, or an efficient, precise answer to a schisto question. And if you're lucky, then those 2 questions have similar optimal answers, but it's rare that they have identical optimal answers. But it does seem to me, from a wider multi-program perspective, an obvious direction of travel, not least because also there are multi-morbidity issues all over the place, which you'll only really understand by co-sampling.
So it seems to me that there's a lot of discussion now going on in the chat box and through the talks and the panelists' contributions, that we may be able to merge on some sort of strategies for perhaps identifying the hotspots, but what to do about them. There may be some clear differences that perhaps cannot be reconciled if they are focused on kind of biological differences, whether we're focusing on vectors or whatnot. So we have some comments here from Yael Velleman, one for Narcissus, talking about how WASH is crucial, but we need the right kind of WASH, and how implementing WASH in certain areas and building infrastructure can actually still fail for the same reasons that mass drug administration fails. So I don't know if you would like to respond to that, Narcissus, and give a few last thoughts.
I only want to agree with him, or is it her, with him, that it depends on the type of WASH, and indeed WASH can still also fail the way MDs failed. Indeed, it depends on the type of WASH, because you know, you have also to know which people you are giving, you are talking about. If you are giving, let's say, water, safe water, people are going to the transmission areas to fish, and they must be there. And some of these are extensive areas, and some of the areas are not very deep. Nidification is occurring there, snails are there, transmission is occurring there. Then if you had very clean water, you would still get transmission. But remember, I talked of a combination of all. Snail control, focal, parasiting, if you can identify where the snails are, a lot of health education messages telling the people about the dangers, protective gear you can think of in a particular area, obviously, which varies from area to area. There is no single answer. So you have to handle it carefully. The type of WASH, the type of messages, are there alternatives to the messages we are passing on? So indeed, I agree with him, but I think if you combine everything and you identify the place and you apply the right WASH, then it can be effective to some extent, I imagine. But as I said earlier, research is still needed to get the real correct answers to what to do with these hotspots. Thank you.
Thank you, Narcissus. And I think it's about time that we move towards wrapping up this session. And I just want to invite each speaker, actually I'll put you on the spot, to propose one question that you think needs to be extensively researched to make some sort of progress in identifying or addressing hotspots. Because I wonder, are we still going to be in the same place in 10 years where we're still discussing many of the same longstanding issues with hotspots? What do we need to do to move forward for schistosomiasis and STH? What would be one priority area that you could put forward? So perhaps Peter.
Okay, well, I'm not an expert in these diseases. And from what I see and what I hear over many years now, my top priority, if I had to have one, would be training. It would be building capacity so that more of the work on efficient statistical design and analysis could be done in country, with international partners available to help as needed, but more and more building a statistically capable workforce within low and middle income countries without abandoning them, without actually breaking them off from some of the higher concentrations of infrastructure, technology, and experience in high income countries, but definitely capacity building so that more responsibility and more delivery can be done in country without having to use what, and I mean no disrespect, what are really old-fashioned substandard methods of analysis, which are not making the best use of hard-won data.
I really could not agree more to prioritize scientific capacity. Dan.
Well, I certainly agree with Peter that that is extremely high on the list, and some places need it more than others, and everyone would benefit. I think that from my perspective, in terms of questions that have to be answered, I think that identifying those factors in different hotspots that contribute to there being a hotspot, and they'll be different in different places. Being able to get enough data to extrapolate so you don't have to do it in every single place would be very important. And I think we still, there are several studies, and some are complete, some aren't, on what factors contribute. And I think they'll be different in different places, and it'll be important to be able to associate those with different hotspots. And so we can extrapolate at some point.
Yeah, I think that's really quite interesting. So we're not starting from scratch every time we think we've found another hotspot within the country, especially if there are many, many hotspots, as Narcissus showed us with Uganda. So Narcissus, could you give us your thoughts on what you think is important for research to move forward in this area? You're muted.
There are many things, but I think one area which I know is really not seriously done. Of course, we all have talked and we have not concentrated on coverage, treatment coverage, but still treatment coverage is important. Can it be improved in these areas? Some of these areas, let's say in these islands where population is moving from place to place by maybe placing drugs in health facilities, teaching the health facility people how to manage the drugs, mobilizing the people, and also increasing the people who are managing the drugs, let's say the fishermen, to fish, to treat themselves. If some fishermen moved along with the drugs and they can treat themselves even after MDA and it is continuous, in addition to MD, can all of these factors improve? And the other thing is, of course, to look at types of wash and wash interventions, which can work in settings like these high transmission areas. That's all.
Thank you, Narcissus. So if we can return to some issues that are quite familiar to all of us with a new perspective, that would be quite helpful. And Rubina, could you wrap up for us, and then we'll.
Thanks, Juliet. So again, linking back to what had been said before and shared in this wonderful gathering, I think we need to have a comprehensive monitoring and evaluation approach that acknowledges the different phases of the control program of these diseases. So we were not talking about hotspots 10 years ago. Some of us may have seen them. So it just leads to the later stages of an intervention program. And so I think the M&E approach really needs to consider the program phases. Also, I totally in line with what Peter, you said earlier, developing national capacity to constantly monitor their program situation, the disease epidemiology, the impact, what's happening at different levels, and then be able to not only generate good quality data, but to analyze it, assimilate it, and change that into action. I know these are, it's like a broken record, old phrases, but that's what really matters in the end to control diseases. It's been used by all public health programs. One of our really practical and helpful strategy in building national capacity in science and data application is working with the field epidemiology and training programs in countries. They're there in almost all countries. We are working with that program in Kenya to help them do surveys and make sense of data. So I would encourage you all to kind of look at that possibility. It's always a nationally owned program. They raise and train their own field epidemiologists. They've been used by the polio program, by HIV, TB, malaria, but for some reason, NTDs have not reached out to that program. So that's a good way to go. I'll stop there. Thank you.
Okay, thank you, Rubina. And thank you everyone for attending and participating in this discussion about hotspots. The meeting has been recorded. Yes, and we have many partners to thank, especially the STH Coalition and Children Without Worms, COR-NTD, of course, especially Chelsea for helping organize this, and the Global Schistosomiasis Alliance. It's likely that this recorded talk will be available from GSA, and for all of you that have registered, you'll get a link with this recording. Otherwise, I'll say goodbye for now. So thank you.
Bye, everyone.
Thank you very much.
And on behalf of the COR-NTD Secretariat, I just wanted to thank Juliet and the session organizers and speakers for this wonderful session. For those of you who have attended, thank you so much for your great questions. Please note again that this is the first meeting in a series of meetings from the STH Coalition. So the second one was actually scheduled for last Friday, but has been rescheduled for this Friday, and it is on India's helminth control paradigm. So we do hope to see you there, and thank you all again for your participation.
Thank you. Bye.
Bye now.
Thank you.